Good evening, everyone. First of all, thank you so much, Vijay sir and FRF Forum for giving me this opportunity. Okay, so I'm just going to discuss about the ACL injury and the rehabilitation. Okay, so being in here, I'm in Muscat, Oman. We see a lot of ACL patients, and overall, whole world, the incidence is also too high. For example, in US, almost 100,000 to 200,000 of their population they are getting injured every year. The ACL tear, including partial tear and complete tear. So let's discuss about the injury and basic anatomy and the rehab part. Okay, so coming to the anatomy, it's a dense connective tissue that connects the femur and tibia, and the ligament it is attached to one end to the femur medial side of the lateral condyle, and it runs oblique course and it is attached to the tibial eminence. Okay. So there's two bands, actually anterior medial band and the posterolateral band. So the importance of knowing the band, like when we do the surgery part, when we discuss about the surgery part, it will be clear. Like there will be surgery options like bundle specific. So they'll be doing one bundle at a time. So in that case, the rehab is little quicker. The player can get back to the sport little quicker compared to Okay, so coming to its function, it holds tibia and femur, and it is one of the strongest connective tissues, the ligament, which holds the femur and tibia and hold, and it avoids the tibia anteriorly, anterior translation of the tibia from the femur, and it is one of the most thickest stabilizer of your knee joint. So, okay, etiology, how it get here, whether the grade 1, 2, or 3, whatever. So, there are two different factors like external factors and the internal factors. So, first of all, let's discuss with the external factors, which is the most common injury, like when the foot is fixed on the ground and when the player turns their body and it is twisted and it is getting injured. It is most common in football, basketball, like a bad fall or bad jumping, landing techniques or whatever. So this is usually common in football while they miss the ball and they just rotate. And the next one is a pivot shift, like they are running and suddenly they change the direction without deceleration or even with mild deceleration. They try to change the direction. Again, it is getting injured. And as I said already, a poor landing this way or a basketball or volleyball or skates over, a poor landing it can cause and a direct impact. And this is also very common in football and in some of hockey injuries also happens this way, a direct blow from the lateral side of the ball. Okay, and one of the most important external factors is the ground, the tough ground. They say like if the turf is too soft and when the player is running and trying to change the direction, it gets stuck with the ground, and when they try to like turn or rotate, and it is getting injured. And next important part is the shoes. And now they are saying the shoe stud height is also very important. Like when the height is little more and or if it is less, it can slip and again they can get injured. So the shoe stud is also one of the most important external factors. So coming to the internal factors, if you are modifiable, if you are not modifiable, for example, like age and sex, a female are more prone to get injured compared to males with the ACL and previous injury without any proper rehabilitation. If they are fatigue, particularly this is very common in even international football. Like in the last few minutes, like the player is already fatigued and like unanticipated situation. Suddenly, when the ball comes, when they don't know how to react and they turn again, they can injure their uh, ACL. And again, limiting dogs when they try to hit with their non-dominant leg, again that can injure like because of bad technique, then lack of skills obviously, and flexibility of their hamstring particularly, and muscular imbalance. Like few, they have very good squat strength and there is no hamstring strength. So hamstring is the another muscle which can hold the tibia from the back. It can also support your ACL ligament. So when the hamstring is too weak and the quadricep is too strong, again it can cause the injury. It's one of the most risk factor. And all these things can be like the flexibility or muscle strength, the aerobic fitness could be modifiable. Few are non-modifiable internal factors. And foot morphology, particularly they say like the flat foot, they are more prone for injury. Okay, so coming to the grades of the injuries. So grade one is just a mild damage, like a slight, it is been stretched, and with proper rest, it should be fine. And the joint will be stable. When we do the test and all, it is going to be stable. And grade two is the partial tear we call. And doctors usually they call partial tear in the MRI like 1% to 19% it will be mentioned as partial tear. So the percentage, it is subjective. So usually the partial tear grade 2 is called as the half tear. And grade 3 is the complete tear where it will be a lot of instability will be there. In grade 2, there will be mild instability could be there. So, and coming to the associated injuries, knee complex, we have a lot of soft tissue which supports the knees, and usually ACL injuries alone is quite not very common. So they usually come with like a medial meniscal injury or medial collateral injury. The most in football players and the skiers, the combination is usually ACL, medial collateral ligament, and the medial meniscus. So this is the combination injury occurs. So other than that, like bony contusion will be there, a tibial eminence fracture avulsion will be there. So all these are the associated injuries which comes with ACL injury. It is said that 50% of the times the meniscus has been injured and 35% medial collateral ligament has been injured with ACL injury. So the signs and symptoms, the most important sign, the player will feel a pop when they had the injury, and there will be severe swelling because of the hematosis, the internal bleeding, and the pain will be there. The player will be like laying down, holding the knees, and will be calling for the doctor. And it is quite difficult to do the test immediately, the attachment test or anterior traverse test immediately. So on the ground, we have to just check and we have to see the seriousness of the injury. You have to take the player out if you feel like it is a quite bad injury. And then another symptom is like the player will feel the knee feels like giving out when they feel that the slippage they can feel, and there will be a little warmth. Definitely, there will be a lot of swelling, and the warmth will be there. So these are the major signs of symptom. On ground, most of the time, the thing is, it is always good to keep watching the match. Always, you have to keep. We cannot relax like other players or the coach, whatever. At least they can relax. So as a sports physiotherapist, you have to always look into the game, and you have to observe the. You have to just move with the ball, or if you're playing cricket or whatever game it is, you have to just be attentive to players. So by the time you run to the player, you should at least judge like what could be the injury, so that it's easy for us to proceed whether to leave inside or we are going to take him out. So mostly the player will be lying down, holding the knees and just calling us, and we can just go and assess. The immediate special test, whatever test we do, it is quite difficult practically to do inside the ground when the player is having a lot of pain. So coming to the special test, the anterior draws test, it is kept like knee as 90 degrees. So you have to get consent from the patient and sit on the ankle, and we have to just push them. Always it is better to compare with both the legs. Whatever the test we are doing, almost all the 2-3 tests, so we have to compare with the opposite leg also. And pivot shift test, again it is taken like 20 to 30 degree of knee bending. I give some valgus stress, internally rotate the tibia and gradually extend the knee, flex. It will just give a slippage. And the last one test is the most common test we do, like bend the knee to 20 to 30 degrees and gradually give pressure, stabilize the femur and just try to pull the tibia out and in and out. So as I said, we have to just compare with the opposite leg also, like so that we can come to a judgment whether it is being injured. So coming to the treatment part, one is the conservative treatment, another one is the surgical treatment. So conservative treatment, we do a lot of electrotherapy, UST, laser, TENS, IFT or whatever. And few cases like grade 2 injury, we can, those players who don't want to go for surgery, we can give them some brace and we can try and wait for some time. And of course the strengthening exercise, whether they go for a surgery or not, immediately you have to start strengthening the exercises. and taping or whatever considered treatment we can, it's an option, we can do it. And coming to the surgical part, the orthopedic reconstruction, which is most common here, the two types are like single bundle and the bundle specific. As I said, like anteromedial and posterolateral bunch. If there is only one bundle is being injured, they spare the other good bundle and they will repair only the one bundle. So in rehab part, particularly the proprioception will be little quicker and faster. For example, if a player is able to do 5-6 months post of the sports, he can return to the sport little earlier, maybe 3 months or 4 months. So it depends. So and after the reconstruction, they do like hamstring tendon, patellar tendon, cadaver graft, and the synthetic graft. So here we mostly do hamstring tendon. It's quite easy to get back to the sports. And okay, so coming to the post-op rehab, so the immediate from day zero, for example, after some almost 8 hours from the operation surgery, we are going to start the physio for the patient. So the goals will be like we have to reduce the pain and swelling. Really, there will be a lot of pain and swelling, and we have to start the range of motion, and we have, and the most important part, we have to make sure there is no lag, like no flexion deformity, fixed flexion deformity is there. So you have to make sure that we have got a full extension. Maybe we can keep some pillow in the ankle end, and we have to maintain the flexibility of the hamstring. At least this time, we have to just make it straight, not to go for a stretch. We have to keep the leg completely straight, that there should be no lag. And the quadriceps activation, we can start with the isometrics, and we have to maintain the cardiovascular fitness. If it's a serious athlete, we have to start with some hand bike or something. So we have to make sure that he's good with his cardiovascular fitness. And straight leg raising could be started with the brace. Without brace, usually there will be some lag. So better to go with some brace and start doing the SLR. And there will be few players who are very strong, they can even do without the brace. And preferably you have to start with full weight bearing. If pain is a factor, maybe we can start with little like partial weight bearing, but by day 1 or 2 you should be going with full weight bearing. If there is some issue like a meniscal repair has been done or the graft is not good, there will be a note from the surgeon like don't go for full weight bearing. They'll give us the notes. So accordingly we can proceed with the regular ACL like reconstruction. We can go with full weight bearing working, and we should target for knee flexion 0 to 90 degree. Pain might be there. In that case, maybe 60-70 is okay. By the end of 2 weeks, we should be able to do 90 degree. So the exercises which could be done, we can start immediately the post-op day zero, like ankle toe pumping, which will avoid the DVT. It will be good for the circulation. We can start the static quadriceps, isometrics. And these two, like this ankle and the static quadriceps, they can do maybe even every half an hour we tell them to do it. Till they are in the inpatient ward, every half an hour or 1 hour, they can keep doing both the exercise. And the SLR, if it is able, if the patient is able to do without the brace, it's fine. If not, we have to wear the brace, so it's easy for them to do without the lag. And partial repairing crutches or walker, whatever. If the player is too good, even without a walker, even an elbow crutch, it is fine. The crutch is just to support. So if the player is too good and confident, even without crutch or elbow crutch, we can start walking. So the pattern will be like same like a crutch, injured, and like a good leg. So it will be like a crutch, bad leg, and good leg. So we have to teach them stair also. Maybe the patient discharged from the second day and they should be able to climb stairs. So we should tell them like how to climb also. It's our duty. Like first good leg, then bad leg while going up, coming down, first bad leg and then good leg. So and cryotherapy plays a major role immediate post-op because of swelling and pain. It will be really good. The patient will feel. So here we usually do first 2 days continuously. Every 2 hours, we give them 50 to 20 minutes of ice pack. We have got the gel for the knees. We just wrap it up and we keep doing every 2 hours. We'll be doing 20 minutes. So and then after 2 weeks, the stitch has been removed and the patient will be a little okay. You can walk to their OPD without any support or without even brace. The brace is advised usually 2 to 3 weeks. Maximum will be 3 weeks usually. If he's athlete, maximum 2 weeks. He'll be like taking off this brace and he'll be walking. So then the post-op week 3 to 6, the main aim is to get near a full range of motion, minimum 110 or 120, so that he'll be able to do cycling. So by usually by 4th or 5th week, the athlete will be doing the cycle, and we have to start the hamstring stretcher, the flexibility of even other joints also, and control strengthening exercise of your hip muscles and hamstring, quadriceps, and the calf should be started at this phase. it should be control and non-weight bearing exercise. So strengthening of the non-injured leg usually will be starting from day 0. Before even we start the good leg, the injured leg will be doing the good leg also, the injured leg, because we need a lot of strength with that leg. So now we are going to start. Usually proprioception exercise will be starting after 3rd week, like usually 4th to 5th week will be starting. The patient will be like able to stand with one leg, and normal weight bearing gait he should be able to do it. When he is doing normal weight bearing gait, and the proprioception exercise will be a little easier to do it. So it will be vice versa. The more he is doing the proprioception exercise, the normal weight bearing gait will be done. So again, you have to maintain the cardiovascular fitness. Now we have got options like we can start cycling. The patient can start cycling, and even corridor walking. Everything should be fine. So the exercise part, we'll be doing heel drag for the hamstrings, and SLR again. So and VMO exercise like final 15-degree extension exercise, and post-op for the glutes. And this guy is lifting too much. It's not right. So there should be no arch in the lower back. Just little above the ground when you feel that what is it, glute contraction, that itself is fine. And abductors and adductors. These are the regular exercise we have to start the 3rd to 6th week. And the proprioception exercise, initially the basic thing will be starting with one leg standing with eyes open. That is the basic thing we start. And then we are going to close eyes, and then we'll be progressing to the disc or wobble board or whatever. So the initial basic thing is open eyes with one leg. So let them stand like 10-15 seconds, it's fine and good. Then gradually you can tell the patient to progress gradually, like closing the eyes and open, keep on like shifting with that. Okay, and we can slowly start quarter squat. This is almost half squat the picture is showing. The better thing to is to start a quarter squat initially, or even some weak patient will not be able to do this by 6 weeks. Usually they take 8 weeks to start even a quarter squat. And the phases is always not fixed. So it is always depends upon the patient. So some individual will be ready to do a half squat even after a third week. Some will take even 8 weeks. So here we are discussing is the usual one, like majority of the patients, that's the protocol. So again, the post-op week 6 to 9 will be like we have to achieve full range of motion, a complete knee bending, uh, and then we have to start some functional squat of strength, like sitting from the chair and getting up. All those functional training we should start. And now we are going to start the open kinematic chain. So usually minimum first, some patients like weaker patients, like as I mentioned, the open kinematic chain we can start only there is a full ROM and there is no swelling and adequate basic muscle strength. So some people will have even 4-6 weeks, they will have a lot of wasting. So in that case, we cannot straight away start, so that it again weaken the graph. They say the motor will screw in the knees with the open kinematic chain. So the graph get weakened with that high sitting leg extension or whatever. So if all well and good, the strength is fine, we can start open kinematic chain, particularly the high sitting leg extension, and continue with the strengthening lower extremity. What already we have done, like hip muscles, like adductors, abductors, and extensors, all those exercises with full range, including hamstrings. Gradually, we can start doing some ankle weights and exercise. So the advanced proprioception exercise with eyes closed or the Dura disc or wobble board, we can start. And again, increase the cardiovascular fitness. In this time, we can start swimming, cycling, even a slow walk in the treadmill with the speed of like 4 to 5 should be fine with the people. And now even this phase we can start lunging, not lunge walk. Initially we can start with lunge with alternative legs. If the athlete is okay, then gradually you can go with lunge walk and with some weights. And next we can start with the knee extension, high leg knee extension. And note that still 6 months we are never going to start with any resisted high sitting leg extension. They say it's too bad that it will weaken the grab. So only this restriction the player will have. Next, the full squat with weight. These two are the restriction that he is not supposed to do at least for 4 months. And the advanced progressive thing with the Dura disc or wobble board. So whatever equipments we have got, we can start doing with it. And we can start with some weight with the calf and hip and knee extension. So all the exercise we can start with weight. And it's right time to start with their aqua therapy. Even fourth week when the stitch is removed in the second week, third, fourth week, if the player athlete is good, we can start some aqua therapy, starting all the knee and hip range of motions. And we can start the treadmill. this phase with a speed to start about like 3 to 4, it should be fine. When the player is comfortable, we can ask him to go for a brisk walk. When the brisk walk is comfortable, then gradually start with jogging. The jogging is okay, then running, then sprinting. So it should be a phase. It should be very gradual. Usually the players, they'll be too much confident. They'll say, no, no, this is bad. We have to insist them. We should never allow them. We should not be overconfident. We have to always go with phase by phase. Okay. And post op week 9 to 12 is you have to continue the flexibility exercise. Quadricep strength, we have to start some progression. Particularly the knee press, leg press machines we can start, and a lot of lunges should be done, and we can do half squats with some weights we can start. And this phase you have to start a lot of Nordic exercise for the hamstring, like eccentric loading you have to start doing now. So the hamstring part is going to play more major role compared to other muscles, because it is the one muscle, again it is going to hold your femur and tibia. It is helping your ACL. So this phase we have to start more of eccentric loading. So again, progression of the proprioceptive exercises, and we can start a sports specific cardiovascular. For example, if he's a football or a football player, he has to keep on running, jogging with like some time of rest. If he's a cricket player, it is not going to be a continuous running or sprinting. It will be sprinting and jogging and walking. It will be a mixing of sprinting, jogging, and walking. And even quite sometime he can even stand at rest. So depends upon the sports we are training. We have to start their sports specific cardiovascular fitness. So this phase we are just going to, with the progression, we are just going to add some ankle weights and gym. So we can start some basic exercise. Not to, we cannot load extremely like how we used to do it. Maybe 50% of the load what we used to do, we can start at this phase now. And coming to the post-op week 12 to 20, so here it's more of a gym workout and a lot of flexibility and strength training. And here the training is more of a sports specific training. If he's a batsman, he has to start with a functional trainer. He has to start with the strokes. And if he's a bowler, he has to start more of the thrower strength exercise is good for the rotator cuff strengthening. And even a sports specific proprioception, like the bowler, he's a right arm bowler, he has to start with more of a proprioception for his left leg. So and a sports specific cardiovascular fitness, as I said, like depends upon the sports, you have to give them the training schedule. So this phase, it's right time to start with your full-fledged fitness, with your proper physiotherapy training. That we cannot just let the athlete to start on his own. Again, with overconfidence, he'll surely do something bad and he'll injure his leg. So it should be done with proper supervision of a physiotherapist or a trained, certified trainer. And the post-op week 20 to 24 is almost the last phase of before he gets into the game. So here it's more of sport-specific training. You have to start agility, plyometrics, and advanced proprioception training, like with one leg and moving the other leg front and back and cross. The lunges, lunge matrix should be started, and the sports-specific cardiovascular fitness should be enhanced almost to a training level, and the strength, power, agility should be monitored, and it should be scheduled and should be noted. So every week the monitoring, like for example, we are checking his muscular strength and endurance. You have to keep note. So almost every week or maximum 8 days, we are going to keep checking the progression. So for example, we can, if he is too bad with his hamstring strength, and we can concentrate more on his hamstring. So the monitoring is very important, and documentation should be must. And back to the sport practice, like not to the extreme level, which level he was playing. So the lower level, he can start practicing all the skills like cutting and like jumping. So all the sport practice he can start at this phase with his physio's presence. And return to sport skills with minimum risk of, this is usually with the prevention program like FIFA 11 plus. They have got PEP programs. So there are so many programs for prevention. So he should be 100% attending that prevention program to avoid the re-injury. So with this phase, we'll be starting with the grounds, with the ladders, cones, and the resistance running. So all these stuffs will be started on the ground. With this, we'll be doing some sports specific sports practice also. Like whatever the game he's doing, he'll not be going to the nets or the practice session. So he'll be little lower to his level. What level he's playing is an international athlete. He'll be playing for a club practice. So gradually, then he'll be allowed to play with the regular levels which are playing. Again, they have got some criteria, and with the balance training, there are a lot of equipment. It's all about the physio's creativity. There is no fixed thing. It's all about the physio's creativity and the need of the athlete. So, what is his game? What he needs, and the physio's creativity. So, we can start a lot of balance training, and with the Bosu ball, step board, Swiss ball, wobble board, and the TheraBand, TheraTip, we can use all the all these modalities. We can start doing the strengthening. Particularly, we have to concentrate more on his strength. And I have missed out the core strength is very important. They have said like a weak core can also again hurt your ACL. So most of the ACL injury happens with your trunk flux. So we have to start training your core. Sorry, I missed out. Right from the 4th week to 5th week, we'll be starting our core strengthening vigorously. So again, the box jump. So on the field with the physio or your trainer, you can start training with your other players. So always remember, you cannot directly go the same level which he got injured or which he was playing. So he should be going one level less, then only he'll be doing that training. Okay, so coming to the post-op complication, there are usual complications. The most important complication is that fixed flexion deformity. This is the most common complication what even I see here, because when the player stays too long from the hospital or the physio session, and he'll not be coming, and this usually happens when the player usually flex his knees immediate post-op days. So that's why we have to insist the patient to always keep the brace on, particularly when they sleep. So this should be avoided. And to, if you find even initial days, you have to keep some pillow, one or two pillows at the ankle level, and ask the player to keep on doing the quadricep isometric. This will be fine. It is quite easy to correct in initial days, less than a month. If it is going to beyond a month, particularly after 6 weeks, it is going to be really a big issue for the player, and he'll have that like walking. He'll be having that like almost limb length issues.
Dr. Vijay, you have
So
5 minutes.
Have to correct it. Yes, sir. So you have to correct it. There are forward flexion, fixed flexion deformity with that, and restriction ROM is one of the other complication. Particularly quadricep wasting with the player is not with his up to the mark with the strength training, and the graft failure is usually maybe while doing the surgery the graft is okay, and with that yeah, like high sitting leg extension exercise like open kinematic, if they start much earlier or they do with the leg extension with weight, this can even failure the weaken the graft, and infection is one of the other complication. And again, osteoarthritis. If they don't go for a surgery, also there is a lot of chances to get arthritic changes. Even with osteoarthritis, post racial surgery, they can have the osteoarthritis. That is also one of the main complication which we get. So the most regular complication is that fixed flexion deformity. So return to sport, there are some criteria in international athlete level, in lower level, zone level, and even premier season level. Like we usually don't go with the return to sport. If he's an international athlete, we have to go through these things and just read out the stuff. Like he should get fit to play with the sports physician approval, an MRI based graft maturity done by an orthopedic surgeon. A personality type is he should be confident, because if the player is not confident, it's quite difficult to go on and start with his regular game. And level of the sport which he is playing, and lower level you have to start. An adequate full range of motion should be there, and balance and proprioception should be fine. A stable manual ligament stability step like our special test should be done. A manual muscle test should be done with the dynamometer or even manually with the physiotherapist. And functional test should be done. Sport specific testing, whichever the sport is into, you have to give some stress to that particular muscles and test. And there are a lot of prevention programs, as I said, like PEP program, FIFA 11 plus. There are so many programs. You have to make sure an international athlete to attend this program before he get back to his regular sport. And continuing with that outcome, there are so many scales. It's more of subjective from the players, like ACL cruciate ligament return to sports injury scale is there, international knee documentation scale, IKDC is there, KOAS, and Tampa Kinosophobia Index and Activity of Daily. So these are the scales. It's more of subjective. You have to, there will be some 10 questionnaires. You have to ask the patient 0 to 10 or 0 to 100 sometime. So you have to numbers, and we have to produce this outcomes to the surgeon. So thank you all, and open for questions. So Vijay sir, I'm done.